Rebecca Hyde, Mackenzie Harpine, William Morales, Michael Hagerman, and Ashley Lambert, we all did case 15. So our case is about a 14-year-old male named Firkin, and at the age of 14, he was having symptoms of granulomatous skin lesions that were on his nostrils, nose, and lips. He also lost vision in his left eye. His past history showed that when he was 6 months old, he had frequent reoccurring respiratory infections and meningitis, and his height and weight were normal for his age. Then we learned about his 20-year-old sister, Irene, and she had the same recurrent respiratory infections. And they also had other siblings that had no history of unusual health. Irene showed strep and influenza in her test results. Firkin had anti-toxoplasma, IgM, and IgG levels, and they were positive. For his treatment, he was started on an anti-toxoplasma therapy and an IVIG. And after the first week, his fever went away and his symptoms improved. After 22 months, his IgM levels were negative and his IgG levels were still elevated. Molecular typing was done, and this showed that Irene and Firkin shared MHC haplotypes, and it also showed that the affected children were homozygous for these haplotypes, and the non-affected siblings were heterozygous. They also had a flow symmetric analysis done of PBMCs from both of them, as well as peripheral blood lymphocytes, and his diagnosis was an MHC class 1 deficiency.
All right, just to explain a little bit of the jargon better, the persistent granulomatous skin lesions were a distinctive pattern of chronic inflammatory responses in his skin due to reactions against various organic and inorganic antigens. Bronchiectasis is a condition where the lungs are damaged and the airways can allow that bacteria mucus to build up and pool in the lungs and can result in the infection and blockages of the airways that he had. As we mentioned, he had meningitis when he was 6 months old, and meningitis is an inflammation of the fluid and membranes surrounding the brain and the spinal cord. Bilateral diffuse bronchiectasis is what his sister Irene also had. And this occurs when a causative disorder triggers inflammation of the airways. And this is caused by inflammatory mediators being released from intraluminal neutrophils. The inflammatory mediators destroy elastin, cartilage, and muscle in the airways and result in irreversible bronchodilation. It also noted that she had some wheezing and cracking, which wheezing is just a high-pitched sound that's heard when breathing and can sound like whistling. The sputum, that was the thick yellowish color, is just a mixture of saliva and mucus that can be coughed up from the respiratory tract. The Haemophilus influenza that was found is a gram-negative bacteria. It's coccobacillus in shape, and it is spread to others through respiratory droplets. The bacteria can invade spinal fluid, which can cause meningitis, or bloodstream infections, which are bacteremia. The pyrimethamine sulfadoxin is the medication that they were treated with in the hospital. And it is two medications. So the sulfadoxin is a sulfa medicine, and the pyrimethamine is a combination drug that is used to treat malaria. And the pyrimethamine is the most effective drug for toxoplasmosis. They were also given TMP SMX prophylaxis, which is known as cotrimoxazole, and is an antibiotic used to treat a variety of bacterial infections.
So, as far as the test results go, a wide array of tests were run on them, including immunoglobulin levels, in which they both tested relatively normally. White blood cell counts were done, lymphocyte tests were done. B cell and T cell tests were done on both of them, with IREM having a high T and B cell, while Firkin only had a high B cell count. Their neutrophils were relatively normal. Their complement was normal, of course. And the DTH response to BCG shows that they had either been exposed to tuberculosis or had been vaccinated for it. The PPD being over 5 millimeters at 20 for IREM shows also infection. The fact that there was no candida meant no yeast infections. And their lymphoproliferative responses were relatively normal. The nitro blue tetrazolium test being positive was a good thing, because negative is seen as bad. As you can see here, I have the normal ranges for all of these tests, which they mostly fell in between, with the few exceptions I mentioned earlier. So what I'll go over now is what each test is really used to determine as far as illness goes. Immunoglobulin results are used to determine if there's an infection and the level of immunity in our bodies. White blood cell counts screen for a wide array of diseases and conditions, as well as infections that affect the white blood cell count. Lymphocytes are a type of white blood cell that are screened to see if a high count can mean infection or inflammation. B cell tests are what's used to screen for possible cancers or other diseases. CD4 and T cell tests are ordered for people with weak immune systems, usually in HIV and AIDS, but also in their case as well, since they had recurrent infections. Their immune system was clearly weak. Neutrophils are tested, and depending on if it's high or low, it can mean different things. High is usually for infection. Low can mean deficiency disorders. Complement is the measure of the activity of complement proteins, which of course the complement is an important part of your immune system. DTH response looks for the presence of CD4 T cells. So the response being that there had been exposure if there is a response, which in the case of BCG and PPD, there was a response. And then the lymphoproliferative response is a specific immune response that entails rapid T cell replication, which what this does, this tests immune competence. And then the nitro blue tetrazolium test tests if an immune system can convert nitro blue tetrazolium to deep blue, which is a test for chronic granulomatous diseases.
Okay, I'll be running through just some overarching background information about how each of these lessons incorporate to the actual case itself. So the genetic organization of the MHC. Firstly, the MHC is a group of genes that code for the cell surface proteins, and these assist the immune system in recognizing what cells are native to the body and what cells are foreign. That could be pathogens or just infected cells in general. There are 3 classes. Class 1 is in charge of presenting antigens found within cells themselves. And then class 2 are in charge of presenting those found outside of the cell. And then class 3, these don't function the same as to say they don't actually present any antigens, but rather they secrete proteins that help with their immunological functions, such as the cytokines and heat shock proteins. Antigen processing is this process in which these specialized cells actually gather information of these antigens, whether it be by breaking down certain proteins or the actual cell itself, and gathering that information and presenting it so that the immune system can recognize that something is wrong with that cell and kind of begin its response to it. Each of the 2 classes that present this information present it in a different manner due to the location they're in. So the class 1 of these complexes are transported via the endoplasmic reticulum, and it does this because it is intracellular, so it uses what's already there to kind of project outwards what can be found within the cell. Whereas the class 2, since they are focused on the outer part of the cell and can't use the same method, they're dependent upon phagosomes instead. And then the CD8 cells, the function of these cells is to work with the TCRs, and they kind of act as a signal to confirm that an antigen has been found within the MHC of that cell and kind of begin its process of inducing apoptosis if necessary. Now, for question 1, for what cells would normally have an MHC class 1 protein molecule bound to its membrane, these would be any cell really that has demonstrated an infection of a foreign pathogen. So all cells that have a nucleus and are within our body that are native have these MHC proteins to assist the immune system in knowing that it is part of the system and is not to be attacked. Now, by becoming infected, this is able to just show to the immune system that there is an infection ongoing and an immune response is required in order to alleviate the issue.
For question 2, it says, in this case, B cells from both patients produced normal amounts of MHC class 1 mRNA. Why wasn't the protein present on the surface of those cells? So many patients who present with the MHC class 1 deficiencies can have mutations in their TAP1 and TAP2 genes that are involved in the protein loading of the MHC class 1 molecules. And Firkin and his sister Irene both had TAP deficiencies. So the HLA class 1 heavy chain and the B2M complexes were peptide and protein free because of that.
So for question 3, it says, why did the MHC deficiency lead to low levels of CD8 T cells but not CD4? So MHT deficiency would lead to low levels of CD8 T cells due to the body being unable to recognize these cells as native and would think of the cells as a foreign entity that needs to be removed. The reason the CD4 T cells are not affected is because they have an inverse relationship. So when one goes up, the other comes down, and vice versa.
So for question 4, it says, why did Irene and Firkin have high levels of IgG? And this is because that IgG is the main type of antibody found in blood and extracellular fluid, allowing it to control infection of body tissues. So these levels are typically high because of allergies, chronic infections, or an autoimmune disorder. So in this case, it would be because of the deficiency of the MHC1, and it is an autoimmune disorder.
And here is our lovely works cited page.